Hi everyone. So thanks for your patience on the waiting for this recording. And I'm sorry if anyone's been suffering greatly due to all of the rescheduling, etc. around the events following the storm. I hope it hasn't been too stressful for you, but do reach out to us if you need help with all of that, and or connections for resources at the college as well. We can help direct you to where you might find some help if you need it. But let's start in on mental health assessment from where we left off. For some of you, you're going to see a few slides that we saw last week because one group got ahead of the other, thanks to various excellent questions and discussions. So let's carry on looking at the components of the MSE. And I think there was one issue, that's one question at the end of class that was brought up, just a clarification, because I had mentioned that the handout sheet that Carmen had supplied, which is awesome, with the example questions, I'm just minimizing the screen here that you're seeing so that I can bring that sheet in. Oops, come on computer, listen. There we go, I'll just bring that in. There's that handout. Hopefully you have it open as well. Now I had mentioned that the components were different in the way they're organized, but I think what you really need to understand is that the components are different, but they're the same material is in these two lists. This slide from the PowerPoint represents how your textbook breaks down the material. This slide over here represents how the handout breaks down the material. There's slightly more groupings here. All the same material is included in this list as is included in this list. Just the way it's categorized is slightly different. So this one is more broken down, so it gives a bit more detail than your book does. Your book tends to put things together in a way that then puts like things together and makes the descriptions a little more succinct so that you have less material to plow through. But that little bit of detail helps understand the nuances, because as I mentioned last week, a number of these overlap. The biggie being thought process and content. Now I just have a little frog in my throat. I'm going to pause. I don't know if you'll hear a click or anything on your end, but just a second, please. Okay, so to carry on. So the components of the MSE as described by your book are grouped slightly differently than on the handout. So as an example, the handout here for this general appearance and motor behavior also they include behavior. Oops, I'll just make it purple like the other one. They include, so we're looking at this box over here. They include appearance, behavior, and attitude in your textbook, as well as this number 6, speech and language, in with this general appearance and motor behavior. So there's 4 categories on this handout, all lumped into one on your textbook, but all the same material is there. Similarly, in this sensorium and intellectual processes in blue, they over here, it's all, remember, it's those higher intellectual capabilities that adults are capable of, including level of consciousness, orientation. What else did I think? It was mostly those two. And cognition and intellectual processes are down here. So attention, memory, and intellectual functioning. Those all fall into that sensorium and intellectual processes. What was another example here? So mood and affect are the same. They're both in this purpley. Mood and affect are the same. Thought process and content They're sort of getting into the blue zone here. This handout breaks it up into 2 groups, but essentially the same. Insight and judgment. Insight and judgment are the same. Insight and judgment and suicidality and homicidality are the risk assessment pieces. So the one area where your textbook adds more categories than the handout does is in this sensory, which is looking at things like hallucinations. So hearing things, seeing visual disturbances, whether it's seeing things, an illusion, which is seeing something that is real as something that's different, and I'll explain that when we get to it, or seeing something that just isn't there altogether. But a lot of categorizations, and your handout included, put that sensory category right here into the thought process, form, and content category. So, and so does your handout that asks relevant questions. And really the main point of this handout is the relevant questions that comes in the following pages. And so you can see that in the thought content questions. Do things seem unreal or unnatural to you? It's getting into some delusions in here, but do you ever see visual, hear auditory, smell, olfactory, taste, gustatory, or feel tactile things that are not really there, such as voices or visions? So all of these ones in brackets are the technical type of illusion or hallucination that a person might sense, and that's your fancy pants medical word, the ones there. This is the word, of course, that you would use with the client. See, hear, smell, taste, or feel. So just that clarification came from an excellent question at the end of the class the other day. But let's get into this slideshow here. And I'll get rid of all my, oops, won't let me. Okay, well, I'll keep my scribbles then. All right, so assessment content, starting with the history. So history and appearance are very similar to what you covered in health assessment last year. Looking at age, so I'm going to blaze through a little quickly. Age, developmental stages, which is your content from NA and whoever taught the adult portion of Erickson's type stages last semester. Cultural considerations, spiritual beliefs, all of those things, their previous experiences with mental health, other physical health. I've added these in, so that might be a little different from your slide. They're highlighted here. Physical health concerns, medications, substances, their current concern, their family history. So that's history. And box 8.1 in your textbook mentions some of that. Okay, assessing appearance is looking at dress and clothing. So what is listed here on the slide are the norms. Some common variations might be wearing clothing that's more appropriate for the opposite gender, although of course there's a lot of leniency increasingly in both directions in our society, but certainly for women to be wearing masculine clothing without that being considered terribly variant relative to men wearing women's clothing. As well as unique or exaggerated applications are things of note, of things that may require further assessment because they're an unexpected finding, would be more concerns about dirty, ill-fitting, or inappropriate clothing. So if they show up in wintertime in shorts and sandals, you'd be concerned about their judgment and what their perceptions are, or appropriate also to the time of day if they're showing up outside a hospital situation in their pajamas. What does that mean around their coping and that kind of thing. In terms of grooming, there's common variations that you need to be careful aren't your consideration of what is appropriate. So excellent example is dreadlocks, which requires hair to get matted, and so it was fairly typically historically to be seen as dirty, but as many now know, it's easy to keep dreadlocks clean. It's not really what's going on, but further assessment would be required of unexpected findings, like findings of dirty, rotten teeth or foul body odor, that kind of thing. Age, you're looking at the physical age matches the chronological age, so it's common variations though are to look younger because of an active lifestyle, or perhaps looking a little bit older because of a smoking history. But an unexpected finding would be looking significantly older, possibly because of health concerns, also because of various substance uses, or not having resources, or having, in terms of not having appropriate shelter, that kind of thing. And looking at the height inappropriate for age and gender, significantly shorter might be an indication of other medical concerns that need to also be considered along with mental health concerns. Weight appropriate for age and gender is also important to note, especially at the beginning, and especially if somebody's anticipated to be going on medications. Medications, a number of the psychiatric medications involve weight gain. Unfortunately, it's one of the reasons why people sometimes go off their meds. And so you need to sort of have a baseline of what they weighed when they're first coming to see you. Also, someone looking emaciated or starved would be an unexpected finding that's of note, to see if that is related to their mental health issues. Their facial expressions, so a normal would be that it mirrors the thoughts and feelings they're expressing. But common variations would be things that alter facial expressions, like somebody having had a stroke. So you need to make note of that so that it's seen as normal. And if something like that shows up, then you know that's a change that needs to be followed up. Unexpected findings would be that facial expressions don't match the expressed thoughts and feelings. So they're telling you they're angry and they're smiling about it. What's going on with that? Eye contact, but the eye contact is very culturally linked. So, but even with that, there is some ability to see if people are avoiding all eye contact, or if they're staring directly and constantly into the examiner's eyes. That can be, it's not really a cultural variation at that point. Those can be linked to mental health concerns and need to be followed up. Also, with this is the expected behaviors and motor activities, so looking at posture and positioning. So the normal would be erect and relaxed, sitting comfortably, facing the speaker. Physical limitations might be a normal variation that you'd see, but requiring follow-up might be slumping or hunched, or if they're very rigid, if they're sitting in the fetal position, or they're not wanting to use furniture, if they have areas that are incredibly tense, their arms are folded really tightly, you need to be asking questions about that. If they refuse to face the speaker, face you. Movements and mannerisms, the normals would be habits, gestures and traits that they're using. They're minimal and they're congruent to the situation. They're not big and expansive movements. And so nervous laughter is a normal variation that might fall under movements or mannerisms, especially at the beginning of seeing someone in an assessment. As they relax, that should sort of taper off. Further assessment might be anything that's excessive or inappropriate to the situation, extreme sort of some of those anxiety movements like finger tapping, or some things are related to some medication side effects like lip smacking or facial tics that are important to note. That we'll get into talking about when the medications that are concerned come up in the top. Also, some people have rocking motions with their body, whether they're seated and rocking back and forth, or if they're standing, rocking back and forth on their feet, and it's important to note that as well. Other movements, there's some people's movements are slowed, and that's called psychomotor retardation. So it takes them longer to make a movement and sort of plan it out. There's also waxy flexibility, which is a side effect of some medications, and that means a person's body can be repositioned almost like a doll. And you'll raise their hand up in the air and it'll just hold there. So it's a side effect of some older generation medications, and we'll talk about those in later lectures. There's also tics, as I mentioned, and tremors, which you may have seen in some of your long-term care clients. And then in terms of attitude, common variations is behavior expressions that are polite, or the normals rather, polite, respectful, and calm. Common variations would be behaviors that are congruent with their beliefs, so determined or indecisive or candid or guarded. Ones requiring follow-up would be things like evasive or hostile or paranoid, controlling or belligerent or bold, which is sort of an attitude that might be linked to certain topics, or it might be something that carries through the whole conversation. And the video we'll watch shows a good example of attitude coming through. You'll see it only shows up in response to a particular type of question. So have a listen for that. And then gait is very similar to your health assessment. Accurate foot placement, smooth, even, well-balanced, and associated bilateral movements. So having alternating arm swing, and your eyes are tracking ahead of you to see where you're going to place your feet. Common variations, though, include shuffling, stomping, swaying side to side, arms held tightly, exaggerated movements, or staggering. So a little bit of review there. Okay, and then speech and language, which again is separate on your handout, but of course we're following your textbook for your study purposes. The handout's a supplement to help you understand questions that you might want to ask. So don't freak out that the categories are a little bit different. So speech and language, you're looking at quantity, and a lot of speech and language overlaps with thought process, and other categorizations will put speech and language in there because that's how the person is getting their thoughts that they're processing out to you. How are they making them communicable to other people? The content would be what's in their thought, or the form of the content would be what's in the thought, and then the process is how do they articulate that out to people. So in terms of quantity, there's a word, a Loggia. Where's my pen here? Now this might click through. There we go. A Loggia. So that's A-L-O-G-I-A. And it refers to a disruption in thought process that's reflected in a person's speech. So that it basically means like A is the Latin-y fancy pant words of saying no of something, and Loggia is anything to do with words. And so poverty of speech is a brief or limited or terse way of speaking, and so a person just has very, very few. It's not even just saying yes and no to answers, it's just having very few word options to choose from in answering. And they only basically respond to question or prompts rather than having language flow spontaneously. Your text mentions rhyming and neologisms. So did I put that on the slide? So no, I'll add it here. Neologisms. So there you see log again, so that's a G. So you know it's something to do with words. And neo, meaning new. So new word making, ism, I don't know, ism just meaning they're doing it. So new word making. And so they'll make up nonsense words in place of words. So watch for that in the video too. I'm pretty sure the person does it. And the rhyming words as well. And then in terms of quantity, some people might be super talkative and spontaneous. And again, that's related to alogia. So they're not only having a hard time finding the words, but there just might not be that many. Or they're, oops, where's my quantity? Right. And then, or they might be very talkative and spontaneous. And quality, that word choice and structure is appropriate to the culture and education in the normals. Common variations for quality include awkward structure, varying word choices, having rhyming neologisms, relevance to question, like words that aren't relevant to the question. If stuff is garbled or they're monotone, they're just speaking in one voice and nothing modulates, and it's very varied and statico like that. So it's there's no intonation in their voice. Volume is another version. Moderate volume, appropriate to the seating, is the normal. Variation would be known as dysarthria. So I'll write that one in as well. Oops. My little pen didn't like that. Where did it go on my thing? There it is. A-R-T-H-I-A. Dysarthria. And so that in that case, a person is unable to articulate. And dysphonia is unable to mechanically speak. No. There we go. Dysphonia. Like that. So in this case, dysarthria, the person isn't able to articulate properly, whereas this one, there might be something that's disrupting their ability to speak due to medication or diagnosis or something like that. There might be a mechanical problem with their mouth that doesn't let them actually articulate. So follow-ups for volume would be if they're yelling, if they're whispering, if they're mute, that kind of thing, if they're unable to increase their volume. And then lastly, fluency. Sorry, I realize I just skipped around a little bit. Fluency is the norm, is able to understand speech, able to identify when unable to understand words. The variation would be aphasias, which are related to stroke or traumatic brain injuries, where a person either can't understand the speech, they still might be able to produce speech, but they can't understand it, or the opposite, they're not able to produce it, but they can understand everything, both of which are incredibly frustrating because you can't make yourself understood. Those are often related to actual head injuries. The follow-up in mental health scenario is if a person doesn't understand or gives an inappropriate meaning. So let's have a look at a video. And so this is a video in which has to do with appearance, behavior, and speech. And so I want you to notice just a few important things there. I'm just going to pause for a second here. Oops. Oh, shoot. Okay, sorry about that. I got a pop-up there and YouTube was someplace else and not on our video. Okay, so really quickly, what I'd like you to note, a couple things to watch for that I mentioned on the previous slide, but I also want you to note that the psychiatrist in this case does some review from last week, boundary setting, and redirecting. Okay. What I want you to try and capture while you watch the video is answer, how long has this been going on for this client? What the current concern is. A description of their appearance. And just a note on that, this is a British film, and it's set probably 15 years ago or so, 15 or 20 years ago. And so imagine in England specifically that people are a lot more conservative. So an expectation for going to the doctor might be that somebody wears something that they might on another day wear out for a nice supper, that kind of thing, not casual dress. So bear that context in mind as a bit of a stereotype for Britain, but bear that as a bit of a context for how you might want to assess whether this person's clothing is appropriate for the day. As their appearance, their motor behavior, and their speech description. Okay, so let's watch that video. It's now at the right place. It doesn't have ads popping up. Oops, there we go.
Hello there, Mr. Riley.
Hello, all right, yeah.
My name's Dr. Betty, and I'm the psychiatrist.
I'll come and see you because my GP sent me to see you, didn't
Yeah,
he? He said,
yeah.
come and see a trick psychiatrist because then you'll be all right.
Come and see a...
Trick psychiatrist, psychiatrist, yeah.
Oh,
You
right,
must know that
okay.
one, yeah. He said, come and
Yeah.
see because you have time to listen to me.
Yeah.
He's not had time to listen to me, you see, because
Okay.
he's a GP, he's a doctor, but I don't think he's very clever.
Can I just-
He's not very clever because he's not...
Okay.
Get into this, you see, won't let me
Right,
talk
okay.
about this.
Well-
He talked this at some time, but then, yeah, sometimes he doesn't.
Can I just clarify why you're here and why I'm here? I'm the psychiatrist
come
in the
and see you.
emergency clinic today.
Right,
and
okay.
your GP's asked me to see
Right,
you.
so that's what I mean.
Is that right?
That's what no, yeah, because I've got to tell you about this.
Okay,
Yeah,
okay.
and this, because there's important stuff in there. Really important stuff.
Before
in
we
there.
start with
Come
that,
and see
can I
you.
just ask you, what would you
Yeah,
like me to
yeah.
call you, Mr. Riley?
What names?
Yeah.
Names are games, so I don't bother with names, that's just
Right,
stupid.
okay.
Call me John.
John.
Yeah, okay,
John.
what's your name?
Okay, I'm Dr. Betty.
No,
John.
your proper name.
My name is
No,
Dr.
your proper name. Your name's not Doctor.
At work, I am Dr. Betty.
You're Doctor. Doctor who? Doctor who? Diddly dang, waddly dang. It's good day, isn't it? Do you watch that? That's fantastic.
Okay.
Now, what
John,
is... Yeah,
can I
no.
ask you, how old are you, John?
I'm only as old as the woman you feel, aren't you, eh?
Right, okay.
You know, weight the man's artist to his stomach. Oh, yeah, fantastic.
So how old would that make
Food
you,
for the
John?
soul. Nice bit of soul, yeah.
Right.
Eh? No, a bit of fish. Fantastic. I'm hungry. You got
Right.
any food? Any food round here? Wait, down there, you got any food? I'm starving, no?
They won't be able to get you any food.
No,
Shall we perhaps, I'll tell you what,
Okay,
let's perhaps think about
let's
food
get back to
in
this.
a minute.
Let's
Yes,
get- this is
that's a good
important.
idea.
This is important. This
Yeah,
is why I'm here to
okay.
talk to you about this.
Okay.
Tell you what's going on.
Tell me a bit about this then.
Well, this is the work I've been doing. You know,
Right.
This is really important, and it's my cure for cancer.
Okay.
That's what it is. You know, it's all written down here.
Right.
Well, it's not written down. It's here, and it's at home in my books at home.
Right.
What I get from the papers is I get sort of clues as to
Right.
what I'm supposed to do, and how I'm
Okay.
supposed to get the other clues so I can hone it down and come up with a
And
final
how
thing.
long, John, has all of this been going on, would you
It's going
say?
for ages now.
How long would you say?
Ages now. Well, I've been up a week.
About a week?
But this week I've been working really hard on it.
'Cause
It's been
before-
going on longer than a week, but I've been
Right.
working it really hard for this week.
'Cause you
it's the
normally have
numbers,
another...
you see. It's the
Right.
numbers you have to find out.
Am I right in thinking you normally do a different job?
Yeah, I'm a mechanic.
You're a mechanic?
Car mechanic, yeah.
Okay.
Yeah. Manic mechanic, they call me.
Manic mechanic?
Yeah, it was my
Who
mate
calls-
Dave. That
who
my
calls
mate
you
Dave.
that?
My mate Dave, I
Right.
bought showed him this, and he told me, well, he told me to go away because I was bonkers.
He said you were bonkers?
He didn't say go away, he told me to fuck off.
My goodness,
He said,
okay.
he said, fuck off,
Okay.
you're bonkers.
Did he?
Anyway, so he
Okay.
did that. And so I said, well, I didn't think he was clever enough, really.
Right.
You know, because I went to see the doctor about it, because I thought,
Okay.
show him, because he's a doctor,
Okay.
he's been to university, he's done stuff.
Yeah.
Thick as shit. He really he said, didn't have time. I thought,
Right.
how can you not have time to hear about the cure for cancer?
Right.
You know what I mean?
Okay.
Yeah.
Well,
So that's why he sent me to see you, because I'll tell you all about it.
Okay, well, tell
Just
right.
they need adding together, and I have to find some other information on this page. There'll be some ages and page numbers. I have to add those together and take it away from what's on there. Yeah? Right. So that's how I'll do that. And then
what does that number
you'll find other things. That number corresponds to numbers I've got on my chart. I've got a big chart on the wall. Right. And then I'll find that number, and then that adds up to something else. And it's all there. I mean, that's really good. I'm going to get one of those.
What's that?
That's really good. That's a phone. It does the internet and everything, so I'll be able to find out more stuff. Right. You know, that way when I'm out and about. But that's and there's numbers, you see. I'll use those numbers there. You know, they need adding up and taken away from something.
Okay, so I'm just going to pause that a little bit there and move it along up here. But you can watch the rest of this. Remember, the link is embedded in your slide. And just move along to this point here because there's a bit of repetition there.
I could have got lost in the post and somebody got it by mistake, but just hoping nobody's stolen my ideas, really, because that's what it is.
Sorry to interrupt. It sounds, John, as though this has all been keeping you really busy.
Really busy, really busy.
Have you been sleeping at all?
No time to sleep. No
time to sleep.
No.
When was the last time you had a good night's sleep, would you say?
Don't need it. I've got some enthusiasm from God. You know, it's there, so there's energy inside me.
So you feel as though you've got a lot of energy.
Yeah.
And how are your thoughts? Are they going fast? Are you thinking
because I have to think very intensely. You know, I mean, you look at stuff down here. I mean, there's not. I got that in the door the other day. You know, and there's lots of numbers on there, and they're adding up and taking away.
And John, how are you feeling about yourself? You know, your self-esteem. How do you feel about yourself as a person at the moment?
Fantastic.
You feel fantastic.
I feel fantastic because God's telling me I am. I'm doing a really, really good job. And it's all there. It's all happening.
And tell me this, John, because I couldn't get it from your GP letter. Have you ever had anything like this before in your life, where you felt full of energy and lots of bright ideas?
No. But this has been going on for so long, I can't really remember anything else. Yeah.
And have there ever been any times in your life when you've kind of been the opposite, John? Where you've been a bit down in the dumps, not much energy, nothing like that?
Nothing like that, no.
Okay. No. And what about any family history? Does anyone in your family have things like this?
No, it's just me. Just me. It's really... Well, they're not really that clever.
You're not that clever.
Your family.
Your family.
You know, that's why I have to come and see doctors and don't you, place hospitals and things like that.
Because
you're a clever person.
Do you feel as though you're more clever than perhaps other people?
Yeah. I'm certainly clever than those people at work, because they're a bit thick.
And John, I guess I'm just wondering, what might have happened to start all this off for you? Have you any thoughts yourself to put this on?
God. Yeah.
God?
Yeah.
Okay.
Yeah. And it just came to me one day. One day just came to me. I started noticing connections with numbers and things. Yeah. And it's all there. You've just got to find it. Dig deep and look for it. You know what I mean?
Okay. How have you been feeling physically in your physical health? Any problems there?
Fine. I'm fine. Yeah.
And have you been taking any prescribed medication or even
nothing like
drugs that are prescribed? Any substances?
I just need everything within me now. I don't need anything else.
And you know how...
All right, and we'll just pause it there. Go back to ours here. Oops. And so you can see that even though the client was really distracted by their situation, they're able to answer a lot of questions and give a lot of really rich detail to the psychiatrist. So how long's this been going on? They say some time, but state's really been working hard on it this week. So you can imagine this super high energy state might be just this past week. And what was the current concern? This interaction with a colleague led to this person going to their primary care provider and being referred to the psychiatrist. So this outbreak of high energy and going to the front, bringing all of this material about the cure for cancer into their colleague at work, who sort of flagged this as a concern, not in a particularly caring manner, but still sort of connected, help to get this person connected to their primary care person. In terms of appearance, or in terms of your history slide, at the end there, the part that I skipped to, the psychiatrist was able to get a lot of information about family history and whether they had any physical concerns. There may be things that this person isn't considering at the moment, but remember the mental status exam is just a one moment in time kind of answer, so you could, or type of assessment, so you could get more information on a different day. Their appearance looks perhaps a bit older than the stated age, which I think was late 30s at the beginning of the slide, or the beginning of the video rather. They're pretty forward sitting in posture with rapid hand movements and big hand movements. They have reasonably good eye contact, though they're distracted by their documents. They have some inappropriate mannerisms and phrasings in terms of speech and that kind of thing. And laughing occasionally, as like when he told the story of how his colleague told him to get lost. A really intense attitude that follows along with that sitting forward and that high energy feeling that he's feeling. Strong focus on the resources that he's brought to the appointment, so hard to distract him from that. And his speech is a bit pressured at the start. There's a lot more nervous gestures, so you might have heard that rhyming at the beginning, and that the neologisms at the beginning, talking about the what did they call the doctor, the psychiatrist, the tricky scientist or something like that. So those kind of rhyming, punning jokes and tickety-tack, splickety-splack or something like that. So way more, speaking much more quickly at the beginning with less interrupting. Later on, occasionally monotone, pretty normal volume, although talking inappropriately with other people down the hallway. Some good fluency. Those rhyming words are also called clang associations. He had a bit of limited word choice in terms of history and mood questions, kind of yes, no, good, fine, but not poverty of speech. That's not the same as poverty of speech. That's just monosyllabic answers. And in terms, the other part of the assessment that I didn't ask you to watch for, but that you would have gotten, is looking at the activities of daily living. So you might begin to suspect that maybe he's had some reduced dietary intake, so worrying about nutritional needs, perhaps some reduced sleep, that he doesn't claim to be taking any medications or substances. He has been working, and we know from the history that he lives with his parents. So a lot of detail just in that 5 or 6 minutes of questioning. So in terms of cognition, this is that part that your textbook calls sensorium, intellectual processes, and your handout has broken down into slightly different, slightly more detail. And so it includes things like a person's consciousness. Are they awake, alert, and responsive? Their orientation, so their location to, or their ability to orient themselves to time, place, and person, so that they're able to identify themselves and answer questions about themselves. I'll just jump back to cognition here. Cognition in generally is just the ability to think and use intellect and logic. And so it might vary due to things like lack of sleep and fatigue, medical conditions, drug interactions. And for consciousness, things that might require follow-up would be being confused or unresponsive, and orientation. The requirement for follow-up would be disorientation. So memory, there's questions about short and long-term memory. And then abnormal sensory experiences or misperceptions. So this slide is including sensory experiences under cognition and sensorium, whereas your textbook separates that out a little bit. And then concentration and attention, so being able to complete the thought without wandering. And pay attention without distraction versus not being able to follow a conversation or being distracted very easily. So you could say for that previous video that person has very good concentration because they're very focused on their one topic, but they have poor concentration when it comes to answering other questions. But it's more that they're not interested in that. They're very focused on their topic. Of research the thing that's really drawing them in. And then in terms of abstract thinking, what that means is that they're able to discuss common concepts. So you need to think about that Piaget part of pediatric development that you would have gotten last semester with kids looking at different volumes of liquids and understanding that that just because something changes shape, there's the same amount of volume. So having those kind of abstract thinking ideas is what we're looking at here. So requiring follow-up would be being unable to distinguish between connected concepts. So things that aren't necessarily visible or tangible or concrete, black and white kind of ideas, and being able to make connections between those sort of more abstract ideas. One way of measuring all of these is with the mini mental state exam, or the MMSE. So that gets very confusing because remember what we're discussing here today is the, oops, come on pen, is the MSE, mental status exam, status. So slightly confusing to have it so closely close in letters, but you may recall this from your health assessment. I hope this is a bit of a review. Otherwise, please Google and have a look. But this is something that you do, especially with a lot of older folks with dementias. But it's very straightforward. I'm sure your Jarvis text has a really good write-up on it, and I'm not going to review it here today in terms of the questions that you'd ask. Email me if that's not accurate, but I'm quite sure that it's a health assessment thing. And then assessment content also is mood and affect. So mood is a pervasive and sustained emotion, and it's a subjective experience, and it's reported by an individual and observed by others. So a person may be the mood may also be characterized in terms of its stability, reactivity, and duration. So it really common descriptors, I have them on the next slide, so don't worry about scribbling this down, but things like euthymic or dysthymic, depressed or sad, happy, apathetic, and mood is also very closely linked to some of those activities of daily living, what people also sometimes call vegetative function, so what your body does to kind of grow and is going to happen whether you're up and around and moving and active or not. So energy, appetite, libido or sex drive, and sleep. So you're having a low mood often means having low energy, low appetite, low sex drive, and either no sleep, insomnia, or lots and lots of sleep. Having anxiety, which we'll talk about next week, might often means having high energy, also sometimes no appetite. Sex drive can vary, and sleep goes down usually. So you can see it's not consistent. You need to really be connecting, but it's common for consistencies between depression to often look, as I described it just there, and for anxiety to often look like I described it just there. So it's important to note where a person kind of matches the typical and where they might vary. So just describe what you see is the easy answer. So your expectations around mood is that it's appropriate to a situation, and it might be extreme, but that might suit the situation. So like if somebody's grieving, then you expect outpouring of sadness. That wouldn't be unusual. If they've suffered some sort of injustice, you expect them to be angry. If they're happy, you expect them to laugh at their own joke or their own story. That's totally congruent. What would be incongruent is if somebody's sad at the birth of a baby, or some mood is sustained over a long period of time, especially low moods, but a euphoric sort of super happy mood over a long period of time would also be cause for follow-up as well. So in terms of stability, so that further characterizations there, the consistency of the mood, so how much is it varying? Reactivity refers to whether or not a mood changes in response to external events or circumstances, and duration refers to the persistence, so how long, and that can be measured in hours, days, weeks, or even sometimes years. So affect is the expressed emotion and the facial expressions. So that's the observed expression of the emotion, what you can see. And so there's several components there, and they need to be objectively observed. You don't ask any questions about that, and your handout makes reference to that. On the right-hand column on the handout it's inquired, which means you ask about it, or observed means you watch for it. And so you're monitoring this throughout the interview, and seeing if the affected emotion is congruent with the thought content, and if it's not, then noting if it's not. And so typical things, you're looking at the range of affect. So our fellow in the previous video had a pretty narrow range of affect. He was pretty focused and determined, by and large, with some sort of laughter to some of his stories. Not much change in pattern, pretty intense throughout, and it was appropriate. So it's range, pattern changes, intensity, and appropriateness are what you're sort of thinking about. So some of those descriptions, I have that for you there: appropriate, range, fluctuation or stability, and intensity there. So for mood, euthymic and dysthymic. So little pen. Euthymic meaning good, and thymia just being state of being. And dys meaning bad. So a good state of being overall is euthymic, and a sort of poor state of being. So very general, broad terms, those. Happy versus depressed or sad. Apathetic versus anxious. So not caring about something is apathy. Euphoric is like extreme happiness, and dysphoria is extreme sort of disconnectedness almost. Being angry versus being elated. Somebody being expansive. We could almost say that gentleman in the previous video had an expansive mood. He is very excited, very intense about his project, versus being irritable. I think if you continue to watch that video, he gets pretty irritable and shuts right down at the end. As well as being elevated. Certainly that gentleman was elevated versus being low. And then your affect, whether it's appropriate to the situation, whether the range is broad or restricted, whether the fluctuations are even or stable or labile. So labile just means all over the place, like their mood is changing very quickly throughout. And then intensity, blunted, normal, or flat. So there's a lot going on in the mood and affect one. And remember that mood and affect can also affect this cognition. So what we're going to do is watch another video here. And so have a look at how this person's mood, what they say, and affect, what you see. Do they match? Okay. And does this affect her cognition at all? Is there anywhere that she sort of says that she's having trouble with anything that might fall under the cognition aspect? So let me just find my video here and put it on the right monitor. There we go. So that you can see it too. All right.
Hello, Alison Wells. Do you want to come and have a seat? Hi, I'm Dr. Taylor, one of the GPs at this surgery. What would you like me to call you?
Alison before.
Okay. So what's brought you here today, Alison?
My sister's noticed I'm just a bit fed up, really.
Right, okay.
My sister said I should come.
Right, okay. Has this been going on for some time?
Yeah, a few. I just think things seem to be piling up.
Right.
I just don't seem to be coping with things.
Right, okay.
With kids and things.
Right, okay. Would it be okay, Alison, for me to ask you a few more detailed questions about how you've been feeling? Okay. Well, if we start with asking you a bit about your mood. How have you been feeling in yourself?
I feel a bit fed up. Wake up in the morning, everything just seems very black.
Right.
It's just like swelling and treacle, really. I just don't. I think by tea time the kids get home, so I've been having a fairly decent conversation with them.
Right. And can I just check, Alison, when you say things feel very black, do you mean you feel very miserable?
Fed up, miserable.
Right. Okay. And what about sort of feeling tearful? Has that been happening?
I dropped some sugar the other day. I just burst into tears.
Right. Okay. So is it the slightest thing that would make you feel tearful? Things that perhaps wouldn't ordinarily bother you?
Yeah.
Right.
My sister's noticed as well.
Right. Okay. So you've been feeling very low, and there's episodes of tearfulness.
Yeah.
What about other things? What about your energy levels? Are you managing to keep up with things?
I used to do a lot with the kids. I used to go swimming, playing, but now I just spend the day on the sofa, really. I just have to go to work.
Right. And just remind me, what is it you do for your job?
I work in the supermarket.
Right. So how have you been managing at work?
I've not been going in as much because I just feel so exhausted. But I mean, we're just not. The supermarket's been taken over and they've cut the wages.
Right.
And I'm having problems with the bills.
Right.
And it's like the catalogues, they're just writing the letters. You know, the kids, they want all these new games and stuff. And it's just, you know.
I think things are really difficult all round. Okay. With all this going on, how are you sleeping, Alison?
It takes me ages to go to sleep. I used to read a book.
Right.
And just drop off. But now I just spend my time looking at the clock. So it goes round and round.
So from actually getting off to bed and getting off to sleep, how long is that taking?
A couple of hours probably.
Right. Okay. Once you actually sleep, are you waking up much during the night?
I wake up about, last night I think it was about 4 o'clock. I wake up.
And can you get back to sleep from that time?
No.
And then when you're actually getting out of bed in the morning, are you still feeling tired at that point?
Just exhausted. I feel like my brain's not been switched off.
Right.
And I'm just exhausted the next day.
Okay. What about eating? What's your appetite been like while you've been feeling like this?
I used to have quite a weight problem, but the last couple of months I'm just a bit looser.
Right.
I just...
Do you know how much you've lost?
No. The kids come in from school and they make their own stuff and I just don't bother really.
Okay, so your appetite's gone down as well. What about things like concentrating on your memory, both when you, I don't know, watching TV at home or out when you're out doing your job? How have those things been?
Well, they're pretty useless with the kids. I've got the swimming money last week and PE kit and parents even.
Right, okay.
Well, I just start one job and I'd like I'm not explaining myself very well. It's like the television. I used to like watching the soaps, EastEnders or something, and now 10 minutes later I just thinking of something else.
Okay. And what about things, Alison, that you used to enjoy?
Nothing really. As I say, they're a bit useless with the kids. I used to enjoy going out.
Right.
I used to go out with my friends, the pictures and things. But of course, now I just can't be bothered.
Is it you can't bother, you don't feel like it as well?
What's the point, really?
Right, okay.
You know?
And I was going to ask, how old are your children now?
I'm a bit later in life. It's took a long time for me to have them. I've got a girl and a boy. One's 11, one's 9.
And looking after children takes a lot of time and energy. How are you managing to keep up with that, feeling as low as you do?
I'm a bit self-sufficient, really, the kids do. They're coming from school, get their own tea.
Right.
I should be doing more for them, really, but no, I'm just being useless at that at the moment.
Okay. And what about looking after yourself?
Well, you can see I'm just a mess. Dave used to say, that's my boyfriend.
Right.
I used to, not have much money, but I just take a bit of pride in what I was doing,
Right, okay.
And my hair and stuff, but I can't be bothered with that now. There's no point, really.
Okay. And you mentioned Dave, that's your current partner. How long have you and Dave been together?
About a year. I met him at work.
Right. And how things, because often when people feel really down, it has a real impact on everything, including their relationships. How are things between you and Dave at the moment?
But he's not ringing as much. He used to text. But he's going, he's getting fed up with me not wanting to go out and things.
It's a slightly embarrassing thing to ask about, but I guess it's important. Often when people are really feeling very low, it affects everything in their relationship, including things like the sex life. Have you noticed any changes there for you?
He's always trying to pressure me a little bit and stuff, but I'm really not into that at the moment.
Okay, you just don't feel like that at the moment. Okay. So can I just recap, Alison, and check I've got this right? For the last few months you've been feeling really down, no energy, problems with your sleeping and eating, problems with concentrating, not really enjoying things, and actually struggling a bit with the kids, and perhaps some difficulties in your relationship with Dave. Have I got that right? Okay. Can I ask, Alison,